what we have is this will work for both trauma and medical on these normal findings. When you look on your sheet, you're able to see that. To move my cheat sheet a little closer. So when we look at here, and we'll fill in all, if you don't know all the abbreviations yet, we'll fill in these abbreviations in a little bit. But it's when you start your patient assessment, you want to systematically start from the head and work your way down to the feet. If you do anything else at the beginning, you're going to get confused, just like everybody else in the past has, all right, and forget something. So the initial assessment, until you guys get really good at patient assessment, and when you start at the head and work your way down to the feet, this sheet sort of gives you the normal findings. So when we've done all of our ABCs, we've got their chief complaint, we're focused in on our, their treatment, and now we're just going to do the physical exam. So we start up here at the head. That's what the HEENT stands for. Head, ears, eyes, nose, and throat. So that's what we're going to look at. So we look at the head, and that on the medical patient, that ATNC stands for atraumatic normocephalic. So no trauma, right? Atraumatic. There's no trauma, and normal cephalic head. So the head is normal. That's just a big way of saying the head's normal. You don't need a lot of, you look around and say, okay, everybody's atraumatic normocephalic. Even if the head's a little jacked up a little bit, normally, have a big scar or something, it's sort of still, not a laceration, but something that's normal for the patient, then it's atraumatic normocephalic. And these are all standard abbreviations that you can use. The next thing you look for to see if there's any fluid coming from the nose or the ears, we're primarily looking for blood or cerebral spinal fluid. Like in a head injury, if the base of the skull is fractured, you'll get some leaking of cerebral spinal fluid through the nose and maybe even to the ears. Now when you look for bleeding, like bleeding out of the ear, it's not the ear that's bleeding, it's bleeding from the ear canal. So you sort of look in the ear canal and look at the nose, make sure that there's no fluid in the ears and nose. Next, to look at the pupils. The pupils, that acronym PEARL, that's the one I had trouble with the other day, huh? Pupils equal and reactive to light. See, I didn't have my cheat sheet. So when we shine the light in Frank's eyes here, the norm would be when the light comes over, the eye's going to constrict. And then when you take it away, it's going to go back to its normal size. Then you come over here to the other one, shine the light in there, and take it away. And like we talked about the other day, the pupil gauge on here, so I always have to look. I also go, well, okay, Frank's pupils are about at a 4 millimeter. So I can document pupils PEARL, or just put PEARL, at 4 millimeters because of the P, right? Because if you put pupils PEARL, it's like pupils, right? So PEARL at 4 millimeters. You palpate the neck to make sure the neck is soft and non-tender. There's no rigidity to the neck. Feel the thyroid cartilage and make sure that it is in the midline. If it's not in the midline, then that's a sign of a tension pneumothorax. So in trauma, that's an important assessment tool that we have. And also, you want to palpate the C-spine. You're looking for any type of crepitus. Crepitus is bone fragments. Good thing to do to until you feel bone fragments or until you feel crepitus is go to Walmart, make sure nobody's around, grab a bag of rice, and just fill a bag of rice. And then put it back if you don't buy it. And that's why you want to make sure there's nobody around. People will be looking at you like, what they're doing with that rice? But as you feel that rice, that's a sort of like crepitus. Crepitus is just bone fragments that you feel through the skin. So there's no crepitus. The neck is soft and non-tender. And the last thing you check for is jugular vein distension, or JVD. Now that you have to check at a 45-degree angle. the patient has to sit up at a 45. And then you have to turn his head at a 45-degree angle. Now, Frank had JVD, which would be pretty crazy, huh? Since he's plastic. But you would see jugular vein distension here. Now, what is that telling you that you can't check in a trauma patient? Why can't you check jugular vein distension in a trauma patient? Right, you can't do this, right? That can't turn their head. In a trauma patient, if they have jugular vein distension, they will have it when they lay supine. That's a sign of a cardiac tamponade. So that's life-threatening. So if they have jugular vein distension in trauma, it could be something life-threatening. So you got through the head and the eyes and the ears and nose and throat. Now you move down to the chest. You observe for symmetrical rise and fall of the chest. You go ahead and listen. That BS is bilateral breath sounds. So you take your stethoscope, listen for on each side at the apexes and the bases, and compare the lung sounds. Make sure that right now, just make sure that they're present. We'll learn the different lung sounds a little bit later, but make sure that they're present. You look for good symmetrical rise of the chest. You examine the chest. On a medical patient, a male medical patient, it's not that big of a deal to pull up his shirt, right, and to inspect the chest wall. Not too many men are going to have a stroke over this. So you look, you pick up the shirt, you palpate the anterior chest wall and the ribs. You look for any kind of bruising or deformity. All right, there's no crepitus, there's no discoloration. Now, on a medical patient, female, they might have a stroke, right? If you come up here and say, oh, I got to look at your chest wall. You can still do the exam without really exposing the whole chest. You have to do the same exam. So if Frank was a cross-dresser here, and then, so I would here and I could palpate the upper chest wall, all right? And then squeeze over here on the ribs to make sure it's still, that there's not any tenderness, right? On a trauma patient, it wouldn't matter. If we suspected male or female something wrong with the chest, we'd probably just cut the shirt off anyway, so that way that we could see. Because everything in the assessment, you really want to be able to visualize it, but you have to be cautious at times, right? You just don't want to expose the patient. So we visualize the chest, good bilateral breath sounds, no deformity, no discoloration. We move down to the abdomen. You need to expose the abdomen before you start palpating it. The patient could have a aortic aneurysm, abdominal aortic aneurysm, and you go in and push on his belly, and you rupture the aneurysm, right? Or you have a big discoloration or distension there or a pulsating mass. So male or female, it doesn't matter. You want to expose the abdomen, inspect the abdomen for any discoloration or distension, and then palpate all four quadrants of the abdomen. So you palpate the top upper quadrants. Remember, the belly button is the dividing line. So you palpate the upper quadrant and the lower quadrants of the abdomen. You look for distension and discoloration, tenderness. It's supposed to be soft and non-tender. All right, so the belly looks good. Make sure I got all my belly things. Abdomen soft, non-tender, no distension. You palpate all four quadrants. On the pelvis, you just push on the pelvis to make sure that it feels stable, that there's not any movement in the pelvis. And then you work your way down the lower extremities. What I like to do, again, you don't necessarily have to do it in this order, but you get all of it done eventually. So what I like to do here, some people come up to the upper extremities after the pelvis, but I just go ahead, pelvis is good, close the legs up, look at that open femur. But so you go down through and I palpate the legs all the way down, okay? I check to make sure that the legs are the same temperature. What do you do if this leg is warm and this one's cold?
Something wrong with
Yeah.
the
Huh?
leg.
Yeah, you might have a clot, you might have a circulation problem. So you make sure that it's warm, the same temperature all the way down, that they have good sensation, they can feel you touching all the way down. Check dorsal pedal pulses, distal pulses down here. You can check capillary refill on the toes. And then since I'm down at the feet, I'm going to go ahead and check plantar flexion. So I'm going to put my hand up against the patient's foot and have them push down like they're pushing down on the gas pedal, right? And then extension, I'm going to put my hand on the top of or the back of the foot, the top part, and have them pull forward. So plantar flexion, back and forth. This actually tests a cranial nerve. I can't remember which one, but it tests one of the cranial nerves. So plantar flexion. And so you've done the circulation down here in the sensation, then and you're looking for edema, swelling, there's no edema, and then you can go up top and do the same. So you go down, you feel the upper extremities, you sort of expose, you look, see where the injuries are. Look at that good wrapping job, who did that? Hands are still on. So you get down to the hands, you have them squeeze your hands, make sure they have equal grips. Then I'll do two more pulse points here. I'll check bilateral radial pulses, right? Now I've already checked distal pulses. So now I've checked my pulses times 4. I've checked radial pulses and I've checked distal pulses with capillary refill. So I've checked 2 forms of circulation in the lower extremities. You can also check capillary refill. Remember, that's supposed to be less than 2 seconds. In both hands as well to do that. So, the other thing is have the patient move the extremities, move all 4 of their extremities. So you make sure that MAE means movement of all extremities times 4. We check the good distal pulses, capillary refill. We're feeling the skin here to make sure it's still warm, pink, and dry, right? And then plantar flexion, grip strength, skin temperature, and there's no crepitus or no discoloration in here. So that is, you see how quick that is. I'm even explaining it out. It's pretty quick. So you get sort of a rapid head-to-toe exam. Now in trauma, you would still do the same rapid exam. The only difference is you would come up, someone holds C-spine on the trauma patient, and then you'd scan the body looking for life-threatening injuries first. Let's say this open femur fracture was bleeding profusely. Then that's a C problem, right? Profuse bleeding. So we want to make sure that we put some direct pressure on there, that we have our partner, whoever, put direct pressure on there to control the C. Now, what we're going to do, we'll practice this with each other, all right? And then sort of getting a good base to work head to toe. You want to do this in the ER, and you'll want to do this definitely on the ambulance. You should have ample opportunity to do it on the ambulance. If you're not getting the opportunity in the emergency room, then you need to make that opportunity. You need to let them know, hey, I'm an EMT student, I've got to do my assessments, and so you want to make sure. The only other assessment that we do, like in trauma, we'd roll the patient over to put them on the backboard, and we'd check the back. We'd feel for crepitus and deformity and tenderness along the spine, make sure there wasn't anything sticking out of the back there. Everybody good? Pretty quick, head to toe. If you don't do this, then you start doing, I'll listen here, then I'll go down here, then I'll test grip strength. Eventually you're going to forget something that you're going to need to check. So, I don't do it systematically like that anymore, but I get everything covered. Because I have a sort of a template that I go off of. So I want to make sure that the same way that you have notes there, I have sort of notes on my computer that I do my patient reports on. So I'll look at that template and go, oh yeah, I need to check distal pulses or grip strength. Each one of these things that are on these tells you something that could be potentially wrong with the patient. Like bone pupils, we talked about the pupils last time. JVD in a trauma patient, cardiac tamponade in a medical patient, congestive heart failure. That sound familiar? So unequal grip strength, what could that be? Stroke, right? We talked about the unequal skin temperature. You could have a clot there. So there's quite a few, unequal breath sounds. You could have unequal bowel sounds too. But could be a pneumothorax. Speaking of bowel sounds, we don't usually check bowel sounds pre-hospital. Everybody has so many per minute. I want to think it's 6 or 8 bowel sounds per minute. So if y'all want to listen for bowel sounds, knock yourself out. Now, if the patient your medical patient complaining of constipation, and this patient hasn't pooped in 4 or 5 days, would you want to listen to bowel sounds? Oh yeah, that's a big problem. You want to make sure no bowel sounds could be a bowel obstruction, and that's life-threatening. Nothing you can do about it, but note that, hey, this is a serious thing. It's just not this guy can't poo. He can have a potential bowel obstruction. So see how that changes? You go out there, you guys say, hey man, I hadn't pooped in a week. Oh no, not another one of these calls. Right? And then you go, well, let me listen to bowel sounds. No bowel sounds. Big time problem. You have to listen a while for, I'd listen a good minute or so, because there's not too many. Do you guys have any questions there?